Melbourne's recent detection of N-desethyl isotonitazene marks a critical escalation in Australia's synthetic opioid landscape. As practitioners working at the coalface of substance use, we all need to understand that we're dealing with a mu opioid receptor agonist, that's the same receptor that morphine and heroin bind to, that is approximately 20 times more potent than fentanyl, now circulating as a standalone compound rather than just as a metabolite. This changes everything about our risk assessment and crisis response protocols. Let me give you the pharmacology first, because it matters clinically. Nitazenes are 2-benzyl-benzimidazole opioid receptor agonists, structurally distinct from both morphine opioids like heroin and the phenylpiperidine class that includes fentanyl. Now, this matters because structural differences can affect how drugs are metabolized, how long they act, and critically, how they show up on toxicology screens. N-desethyl etonitazene, a related compound, shows EC50 values, now that's the effective concentration needed to produce 50% of the maximum response, of about 3.35 nanomolar in beta-arrestin 2 recruitment assays and 0.5 nanomolar in direct mu opioid receptor activation assays, and these are both markers of opioid function. To put that in perspective, that's approximately 6 to 9 times higher a potency than fentanyl at the receptor level. The lower the EC50 number, the more potent the drug, so you need less of it to get the same effect. Now, what does this mean for clinical practice? In the Birmingham case series published in Clinical Toxicology, 19 of 20 presentations involving N-desethyl isotonitazene were polydrug toxicities. You rarely see isolated nitazene exposure. These patients presented with complex toxidromes involving benzodiazepines, stimulants, and increasingly Xylazine. And speaking of Xylazine, and this is critical, South Australian researchers find nitazenes combined with this veterinary sedative in discarded syringes. Xylazine isn't an opioid. It's an alpha-2 adrenergic agonist, the same class as clonidine or dexmedetomidine if you're familiar with those. Standard naloxone will reverse the respiratory depression from the nitazene component, but won't touch the prolonged sedation, bradycardia, or the necrotic skin lesions that xylazine causes. You need to manage these as separate, concurrent toxicities. This is mirroring what we have been seeing in the United States, where xylazine-fentanyl combinations, and they call this trank dope, have been devastating communities. Now, for laboratory confirmation, the limit of detection, or LOD, the lowest amount that can be reliably detected for nitazenes in blood, is 0.1 micrograms per liter, with a limit of quantitation, LOQ, the lowest amount that can be accurately measured being 0.2 micrograms per liter. But here's the practical problem. Most hospital toxicology screens won't detect these compounds. Standard panels use UPLC, that's ultra performance liquid chromatography, with time-of-flight mass spectrometry screening for over 1,300 substances. But nitazenes require specific LC-MS methods, that's liquid chromatography with tandem mass spectrometry. Basically, a more targeted, sensitive testing method. Now, unless your lab has specifically added these compounds to their reference library, you are flying blind. You might have a patient in front of you with a classic opioid toxidrome, pinpoint pupils, respiratory depression, altered consciousness, and your tox screen comes back negative for opioids. From an epidemiological standpoint, we've had 32 analytically confirmed emergency presentations between July 2020 and February 2024, with 17 deaths attributed to nitazene toxicity since 2021. But here's what keeps me up at night. 84% of these patients had no idea nitazenes were present in their drug supply. They thought they were using something familiar, something they'd used dozens of times before, safely. Between April 2024 and February 2025, counterfeit pharmaceuticals, primarily fake oxycodone, were seized in New South Wales, Queensland, Victoria, and the ACT, all containing nitazenes. These aren't crude counterfeits, they're visually identical to legitimate pharmaceutical products. The Melbourne detection is N-desethyl isotonitazene specifically, which is crucial for understanding supply chain dynamics. This compound started as a known metabolite of isotonitazene, but has now emerged as a primary compound in its own right. This suggests either a direct synthesis for the illicit market, someone's deliberately making it, or potentially the dealers are selling aged or degraded isotonitazene that has metabolized over time. Either way, it represents an evolution in the drug supply. And here's what this means for your practice protocols. Number 1, firstly, assessment. Suspect nitazenes in any unexplained opioid toxidrome, particularly in patients presenting with extreme meiosis, that's pinpoint pupils, profound respiratory depression requiring ventilatory support, or overdose presentations that seem disproportionate to reported drug use. If someone tells you they took one pill and they're barely breathing, think nitazenes. Remember, these compounds are being found in cocaine, MDMA, ketamine, GHB, synthetic cannabinoids, and counterfeit benzodiazepines, not just opioid products. Your patient might have thought they were taking a stimulant for a night out and end up with a profound opioid toxicity. Second, naloxone dosing. The September harm reduction alert correctly emphasizes that you may need higher or repeated doses of naloxone. Don't be surprised if you're administering 4 to 8 milligrams of intranasal naloxone or multiple 0.4 milligram intravenous boluses. The standard 2-dose protocol may not be sufficient. Document your dosing carefully. This data matters for public health surveillance and helps to understand the evolving potency of what's circulating. Third, harm reduction counseling. Every patient contact is an opportunity, whether they're in your emergency department, your needle exchange program, or your community health service. Emphasize the start low, go slow principle. Even a quarter of a usual dose may be fatal with nitazene contamination. Promote never using alone, having naloxone present always, and using test strips when available. Commercially available nitazene test strips from BTNX can detect 24 of 33 tested nitazene analogs. They're not perfect, but they're a tool in the harm reduction toolkit. The nitazene crisis requires us to fundamentally rethink our overdose prevention strategies. We need expanded toxicology capabilities in our hospitals, integrated harm reduction services in our communities, and properly funded drug checking programs. Queensland's Checkpoint Service detected 3 nitazene samples between November 2024 and the shutdown in April 2025. That's 3 early warnings we've now lost. Those were 3 opportunities to alert the community before more people died. This is public health infrastructure. It's not a nice to have. As practitioners, we need to advocate loudly for evidence-based monitoring and intervention systems. That's all for today, folks. My name's Dr. Fergal Armstrong, and this has been Cracking Addiction.